In this lecture, you're going to have your first exposure to the EKG and what it looks like, and we'll talk about the waveforms and what makes those waveforms and how the electricity in the heart basically translates to these waveforms that we see on an EKG. So the primary learning objectives of this lecture are to understand how electrical activity in the heart translates to the waveforms on an EKG. Hopefully we will understand the three different types of EKG leads, and we'll understand the electrode placement for each of those leads. Then also we'll learn the different waveforms present on an EKG, and then lastly learn how to calculate heart rate based on the EKG. So for starters, what is an EKG? An electrocardiogram is a recording of the electrical activity of the heart, and it exists as waveforms and complexes. So we get this by putting electrodes on the body, and we connect those electrodes via cables to an electrocardiograph. And so we always have to keep in mind that an EKG is measuring electrical activity, not necessarily mechanical activity. So it is possible that some of the electrical signals that you're getting do not completely reflect what's going on mechanically in the heart. That is not the norm, so we usually assume that the electrical activity that we see on an EKG is caused by a certain mechanical activity in the heart, but you just have to remember that is an assumption that we're making. So the concept of lead. So a lead is a recording of electrical activity between two electrodes. So if you have two electrodes, and some leads only have one electrode, but let's say you have two electrodes. One of those electrodes is generally considered to be positive, the other is negative. So any electrical activity that's occurring between those leads or between those electrodes is going to record something on that lead. So a lead is basically a recording of the electrical activity between two given electrodes. And in an EKG, each lead gives us a slightly different view of the heart. So you can think of the leads as kind of like different cameras giving you different views of what's going on in the heart, at least electrically. And most commonly in clinical situations, 12 lead EKG is utilized. So you're actually getting 12 different views of the heart. And these leads can look at the heart in either the frontal plane, and hopefully from anatomy you all remember the frontal or coronal plane. We're going to have 6 leads that look at the heart in the frontal plane, and then 6 other leads that look at the heart in the horizontal or transverse plane. So common configurations, you can just look at one lead if you want. Commonly people look at 3 leads, but like I said, in clinical situations, commonly a 12 lead is used to get 12 different views of the heart, and you get viewing in both planes when using a 12 lead. So here's a picture that kind of gets to what I was getting at with a lead. I'm just going to take one of the more common leads that there is. So if you look at this electrode here and this electrode here, one's negative, one's positive. So actually the electrical activity between these two, this is called lead 2, and you're going to learn that soon. So lead 2 with a Roman numeral. So any electrical activity occurring here is going to record on lead 2, and it runs in this axis. We're also going to have other leads, like for instance, this is lead 1 going across like this. So you can see that we're getting different kind of views of the heart, and this will make a little more sense as we go through this. So types of leads. There's 3 what we call standard limb leads, and they're pretty easy. They're Roman numeral 1, 2, and 3. Then we have what are called augmented limb leads. These are a little bit different, but they actually use the same electrodes as the standard limb leads. And then we have what are called precordial leads. Precordial leads are the leads that look at the heart in the horizontal or transverse plane. So like we said, each lead has a positive and a negative end, and leads can be either bipolar or unipolar. So back to this picture. So I'm just going to take this lead again. So there's an electrode here. So this is lead 2. So there's a positive end and a negative end. All right, so each lead is going to have a positive and negative end. That's important. So the standard limb leads are going to be what we call bipolar leads, which means they actually have an electrode for the positive and negative end. So like we're looking at here, there's an electrode here that's positive, there's an electrode here that's negative. So that's a bipolar lead. The other leads outside of the first three are actually called unipolar, and so there's actually only one electrode. And I know that doesn't make any sense based on what we just said, but here's the deal. So in a unipolar lead, where the electrode is always the positive end, and the negative end of that lead is going to be the electrical center of the heart. So let's say we were looking at a unipolar lead, and I'm just making this up because we haven't gone over the leads yet, but let's say this is the electrode we're using. So it's positive. We're going to assume the negative end of that lead is the electrical center of the heart. So it would be running like this. So that would be a unipolar lead because there's only one physical electrode there. So the term axis we'll use a lot when we talk about this. An axis just refers to an imaginary line between the two. So technically the electrical recording between the two is called the actual lead, whereas an imaginary line between the two is we'll just call it the axis. So I would say like lead 2 is looking at the heart in this axis. Lead 1 is looking at the heart along this axis. All right, so how do these waveforms originate on an EKG? So back to what you learned back in basic anatomy and physiology of the heart. Electrical activity is what stimulates the heart to contract. So the way electricity works in the body, there's a wave of depolarization, and then that's followed by a wave of repolarization, and the heart is no different. So it depolarizes, and then it repolarizes. And remember that due to the cardiac conduction system, there's a very specific path of depolarization going through the heart. So here's the deal as far as how the electricity leads to waveforms on the EKG. So if we focus on the depolarization aspect, so if the wave of depolarization moves towards the positive electrode of a lead, you get an upward, we can also call it positive deflection on that in that lead. So we'll say upward deflection on the EKG. So in other words, if I'm looking at lead 2, here's the positive end, here's the negative end. If the electrical activity in the heart is kind of going in this direction, so it's going more towards the positive end of that lead and away from the negative, that means on the EKG I'm going to get an upward deflection in that on that graph. And then on the other hand, if the wave of depolarization moves away from the positive electrode of a lead, you get a downward deflection on that lead. So in other words, if for some reason, which wouldn't be normal, if the electrical activity was going in this direction towards the negative end of that lead, on the EKG paper you would actually get a downward deflection. So that's what gives us the waveforms on an EKG. It has to do with the direction of that depolarization, which way it's going, relative to the axis of that lead, and whether it's going towards the positive end of that lead or towards the negative end. In some cases, you'll get some depolarization running perpendicular. So let's say the electrical activity is running this way, which again would not be normal in this case, but if it's running like this, you can see it's perpendicular if we're talking about lead 2. If that happens, you could get two things on the EKG paper. You could either get nothing at all, where it just cancels each other out, or you could actually get what's called a biphasic wave, which kind of goes up and then down. So it goes in both directions, upward and downward. So that's what causes deflections on the EKG. Now, there is one other part to this. So not only do we get depolarization in the heart, but we also get repolarization. So repolarization, and at repolarization, everything is just reversed. So if the wave of repolarization moves towards the positive electrode of a lead, you get a downward deflection. If it moves away from the positive electrode of that lead, you get an upward deflection. Same thing if it's perpendicular, the biphasic, or nothing at all. So the standard limb leads, these are the first three leads that we're going to talk about. So remember their numbers from what we know so far of 1, 2, and 3. So they're bipolar, meaning they use 2 electrodes. They record activity in the frontal plane. We use 3 electrodes, and the classic electrode placements are right arm, and they've usually put it on the wrist, left arm on the wrist, right leg, which would be here, left leg here. So the right leg, you're seeing nothing right here. I'll put another picture up. You're seeing nothing here. There technically would be an electrode here. It's just, it always serves as a ground. So everything runs off the left leg electrode. All right, so if you look at this, lead 1 runs across here. So the right arm is negative, the left arm is positive. So this is the axis of lead 1. Lead 2, right arm is negative, left leg is positive. So this is the axis of lead 2. If you look at lead 3, left arm is negative, left leg is positive. This is the axis of lead 3. So there is another thing to discuss here. So looking at these electrode placements, this is not going to work well during exercise, and that's kind of why we're here, because we're talking about the exercise implications of monitoring an EKG. So you can imagine if you tried to run with, or a bike with these electrodes on, you're going to get all kinds of movement, which is going to make the recording unreadable. So during exercise, what we do is move those electrodes off the limbs and put them on the torso. So we move the electrodes off the limbs and we put them on the torso so it looks more like this. So we still get lead 1 running across like this. Lead 2 would run across like this, and then lead 3 like this. So you can see it changes the axis a little bit, but for our purposes, it's not going to be that big of a change. They call this the Mason-Lecar modification, and it's good for anytime you're going to get movement, but you still need to record an EKG. So the electrode placements, so right arm, we still call this right arm, we still call this left arm. So kind of the distal end of the clavicle just below the clavicle on either side. And then right leg, we still call this right leg, left leg. So base of the torso, kind of medial to the iliac crest, just beneath the ribs. That gives you a good placement. All right, so back to the discussion of these leads. So in lead 1, so like we said, left arm is positive, right arm is negative. Lead 2, left leg is positive, right arm negative. Lead 3, left leg is positive, left arm is negative. So those are our 3 standard limb leads. Like we said, you can do the same thing up here in this picture. All right, so now kind of going through the different phases of the electrical activity in the heart and how that gives us waveforms. So I want you to just kind of think about how electricity flows through the heart. So in the healthy heart, normal placed heart, the major kind of axis of depolarization is going to be in this direction. The heart's kind of tilted to the left, and kind of based on where the SA node is and how the electricity flows through the rest of the cardiac conduction system, it's going to kind of go in that direction. However, we're going to break it up into 4 distinct phases. So, but just looking at this moment in time, what type of deflection would be seen in lead 1? So remember, lead 1, the positive electrodes here, negatives here. This arrow is going more towards the positive than it is to the negative, so we would get an upward deflection in lead 1. What about lead 2? Positive was here, negative here. You're going to get a very big upward deflection. Lead 3, positive here, negative here. Still, it's going more towards that positive end as opposed to the negative end. So you're still going to get an upward deflection. Out of those 3, which one would be the biggest upward deflection? It would definitely be lead 2 because it's the most in line with that lead. All right, so the augmented limb leads. These are the next 3. They also look at the heart in the frontal plane. These are unipolar, meaning there's only one electrode. And so the negative end of each lead is going to be the electrical center of the heart. And we use the exact same electrodes that we use. So far, we've only put 4 electrodes on. And that's all we need to get 6 leads so far. And we're not even really using one of them because the right leg serves as the ground. So these are called augmented limb leads because the voltage is really low, so it's increased a little bit, and they call that augmented. So augmented voltage, meaning they're increasing the voltage so you can see it. And the specific ones are AVR, AVL, AVF. So in AVR, the positive electrode is here at the right arm. The negative end would be the electrical center of the heart. AVL, left arm is positive, and negative would be the electrical center of the heart. And AVF, the left leg is positive. So here, or realistically, it'd probably be over here if you're using that modified arrangement. And negative electrical center of the heart. So it runs like this. All right, so those are our augmented limb leads. So kind of in this axis, and then this axis. At least in this picture, realistically, it'd probably be more like this. All right, so the negative end of each lead is the electrical center of the heart. All right, so these are the four phases that we're going to talk about. Instead of just saying depolarization and repolarization, we kind of have to take the heart's anatomy into account here. So we're going to say there's atrial depolarization. So that starts at the SA node. The depolarization moves from the right atrium across to the left atrium. So we get a waveform for that. And it would kind of go in that direction. And then the septum of the heart depolarizes. And it depolarizes like from left to right. So it kind of does this. Boom, like that. So that's a big shift in the electricity, just for a brief moment. And that's going to cause a slightly different waveform on the EKG. And then we have ventricular depolarization, and that's going to flow right down the ventricles like this, right to left, and down. And then we get the magic repolarization. So whatever the last area of the heart to be depolarized starts repolarizing, and it basically goes in the opposite direction. So it'd be reversed, like that. So considering those vectors that I just put in, let's talk about the normal waves you would expect to see in each limb lead. So during atrial depolarization, and you may not completely agree with all of these, but these are kind of for some of these I might even say variable, because it may depend on where exactly you put the electrode. But I'm going to put these up here, and I'll just run through them really quick. So hopefully you can see why in lead 1, which positives here, negative here, the depolarization go like this across the atria, you're going to get an upward deflection. 2, this is the axis of lead 2, upward deflection. 3, we'll say this is the axis of 3, you'd get an upward deflection. I put biphasic or down because depending on electrode placement, you could argue that it might, for lead 3, you might get something like this. Not likely, but you could. So that's why. But for the most part, it would be upward. AVR, remember positives here, negatives here, so you definitely get a downward deflection. AVL runs like this. It could be variable, right, because it's almost perpendicular. But where it is now, it looks like it might be just a little bit upward. And then AVF, which would run kind of like this, definitely would be upward towards the positive electrode. Then we get that septal depolarization, which comes across the heart like this. So hopefully you can see how in lead 1, positive here, negative here, you would get a downward deflection because it's going more towards that negative end. And then we can do the same with the rest of these. So just kind of think through the different leads that we've talked about and where the positive and negative end are, and it should kind of give you an idea of where I'm coming up with this. And like I said, you may not completely agree with all of these, but it's just the ones that I put upward biphasic or down, it just means it could change. If the electrodes are slightly off or the heart's in a slightly different position, it could actually change the waveform. So then we get the ventricular depolarization, and I'll just take the first few. So lead 1, negative, positive, going definitely towards the positive, so upward. We take another lead like lead 2, goes across like this, definitely going towards the positive. And then we'll take like AVF, so positive here, negative in the center, definitely upward. AVR, positive here, negative here, so you get, it's going towards the negative in this case, so you get that downward deflection. And then lastly, repolarization should be basically the same as we just saw, because remember, repolarization goes this way, but the impact that repolarization has on the EKG is the opposite. So it's going toward, and to take lead 1, it's going away from the positive end, so you would still get that upward deflection.